The trouble we're running into is that we're seeing more and more bacteria become resistant to more than one class of antibiotics. We have bacteria that are becoming harder to kill. And these include Staph aureus, which is a common cause of skin infections and soft tissue infections. This organism is becoming increasingly resistant to most of our antibiotics. We're also seeing a number of organisms that are called Enterobacteriaceae. These are gut bacteria that are large causes of a number of infections, and they too are becoming resistant to almost all of our antibiotic classes. So we could be in a situation at the bedside where we're left with little or nothing to offer a patient with a very serious infection, and that's what the nightmare is. We need new therapies. We have a dearth in the pipeline of new antibiotics to treat these resistant infections. The number of new drugs in the pipeline are far fewer than we need. And then we need to think of alternative therapies. Are there things that we can do in addition to antibiotic therapies, like removal of organisms from the bloodstream via some kind of extracorporeal device? So we have to get really creative because the problem is accelerating right in front of our eyes. The goal is to try to decrease the bacterial burden as quickly as possible. There's good data in people with severe infection that for every hour that goes by in a severe infection such as sepsis, that the mortality goes up. And in infections like Staph aureus bacteremia, there's good data that the longer you have the bacteria in your bloodstream, the more likely you are to suffer a complication from that bacteremia, like an infection of a bone or the heart. So what you want to do is hit hard and hit early. And so you want to knock down disease-causing bacteria burden as quickly as possible. So ideally, what you'd like to do is give the best doses of the correct antibiotics as soon as possible, and any other means that you can to remove bacteria. Now, you ask me, how can you remove bacteria? Well, what you have to do is essentially fool them, if you will, into binding something that they normally would bind to. So in a sense, a competitive approach. If they bind to a certain mediator on cells, a certain receptor on cells, you create a device that essentially mimics that approach and has them bind to that in the hopes of essentially just neutralizing their effect and preventing them from depositing in different organs in the body. You'd like to see that perfusing the blood over the actual biomimetic device drops the bacterial concentration and shortens the time that bacteria is circulating in the bloodstream. So those are the types of things that a practicing clinician would want to see. What you'd like to ideally have is a broad spectrum device such that you could give an antibiotic and perfuse over the device, perhaps even before you knew the exact identification of the infecting bacteria. The whole goal is a broad spectrum device that can be used early and doesn't depend on the identification of a specific bacteria. It hasn't been a specific device that's been developed to date to pull out bacteria, but in terms of thinking about the pathogenesis of infections, and the example I use is Staph aureus. We know that the longer you have Staph aureus in your blood, the more likely you are to have a complication. So there is in vitro data with one specific filter whereby you can actually run blood, not on an actual human subject to date, but you can run blood that's spiked with Staph aureus and you actually can pull out a certain amount of Staph aureus on the filter. And the goal is that would be then that you could replicate that in human clinical trials, because if you can knock down the burden of bacteria and perhaps shorten the duration of bacteremia, that should translate into a clinical improvement.